Hello friends, this is Dr. Ganga, your nephrology educator at Prep Ladder. So today we are going to deal with the second part of acute kidney injury, which is diagnosis and its clinical management. Okay. Now what is acute kidney injury? Like we already discussed, it's an abrupt increase in serum creatinine or abrupt decline in the renal function, which is also known as the glomerular filtration rate. Okay. So earlier it was known by a term called acute renal failure. But now that term has become almost obsolete and it is replaced by a term called acute kidney injury. Why this happened is, acute kidney injury, as we know, is any increase of creatinine of at least more than 0.3. So for example, if baseline creatinine of a patient is 0.8 at admission and this creatinine goes to 1.2, then also we have to call it acute kidney injury. Okay. But this 1.2 might be within normal limit. So no one will term or name such a condition as failure. So that is why, for ease of understanding and ease of making diagnosis, it was changed from acute renal failure to acute kidney injury. Okay. Now there are three different staging used for acute kidney injury. First came Rifle criteria, then Akin criteria, then came the KDIGO guidelines. But for all practical purpose, today we use KDIGO guidelines. The difference between the KDIGO, Akin and Rifle is, KDIGO uses only two criteria. One is serum creatinine, another one is urine output. Okay, but Akin and Rifle uses three criteria. First is serum creatinine, then the GFR derived from serum creatinine and urine output. So the important thing to notice here is the GFR calculation is a very tedious job in acute kidney injury. Since the creatinine is not at all steady and it is highly variable, it keeps changing. So it is difficult to use that in situations of acute kidney injury. So this KDIGO guideline became more reliable. Okay. So like I said, two important parameters are used. One is serum creatinine and the second one is urine output. So serum creatinine is any elevation 1.5 to 1.9 times the baseline, or any 0.3 milligram per deciliter increase in creatinine from the baseline. So this is the serum creatinine. Now this, or if the patient has less than 0.5 ml per kg per hour urine output for 6 to 12 hours. Now, what is the implication of this is, maybe if the patient's serum creatinine is normal, it's 1 only. But patient's urine output in a 60 kg patient, if it is 25 ml for 12 hours, then it becomes AKI stage 1. Just because creatinine is normal doesn't mean the patient does not have acute kidney injury. So that is the implication of having both urine output and serum creatinine. Now stage 2 is, first we read it is 1.5 to 1.9 times, right? Stage 2 is 2 to 2.9 times the baseline. And urine output reduction should be less than 0.5 ml per kg per hour for more than 12 hours. So here it was 6 to 12 hours. Here it is more than 12 hours. Okay. And next is, when we see the serum creatinine value, it is approximately 3 times elevation from the baseline. Okay. And if you want to take an absolute value, it is 4. An absolute value of 4 will be taken for serum creatinine. So in any acute kidney injury, if serum creatinine is more than 4, that value will be considered, right? And any urine output less than 0.3 ml per kg per hour for more than 24 hours or anuria for more than 12 hours will be considered as KDIGO stage 3. Now, what is the implication of this staging is, it has prognostic value. That is, patient with stage 3 creatinine will almost go into dialysis. So mostly these patients end up with dialysis. Stage 1 and stage 2 is the initial stage where you can try to reduce the damage, okay, by doing some preventive methods. Now next, coming to the Rifle criteria. Rifle stands for risk, injury, failure, loss and ESRD. Now what is this risk? Risk is, if you notice, the serum creatinine is the same. It says more than 1.5 times. There it was 1.5 to 1.9 times. Here it is 1.5 times the baseline, or here GFR has come. Decrease in GFR more than 25%. Okay. Urine output criteria is less than 0.5 ml per kg per hour for 6 hours. There it was 6 to 12 hours. So here one extra addition is 25% reduction in GFR. Next is injury. What is injury criteria? That means the serum creatinine has increased more than 2 times the baseline, just like our KDIGO here 2 to 2.9 times. Okay, or GFR reduction is more than 50%. Okay. Urine output criteria again becomes the same, less than 0.5 ml per kg per hour for more than 12 hours. Next is failure. Failure is when serum creatinine is more than 3 times the baseline or absolute value of more than 4, or if patient has a decrease in GFR more than 75%. Okay. Again, urine output criteria is the same, less than 0.3 ml per kg per hour for 24 hours or anuria for 12 hours. Now, loss is complete loss of kidney function for more than 4 weeks. So, this R, I, and F is like KDIGO stage 1, 2 and 3. The loss and ESRD, loss, that is complete loss of kidney function for more than 4 weeks, is called as loss. And ESRD is when this ESRD, that is dialysis requiring stage, lasts for more than 3 months. Okay, 4 weeks is loss, ESRD is 3 months, like the CKD definition. So this is Rifle criteria. Then is the Akin criteria. Here stage 1 is same as Rifle risk. Okay, that is what? Creatinine increase more than 1% from the baseline, more than 1 time from the baseline, and an increase in serum creatinine of more than 0.3. Urine output criteria you notice is the same. Stage 2 is same as Rifle injury, that is more than 2 times the baseline. Urine output less than 0.5 ml per kg per hour for 12 hours. Okay. And next stage 3 is failure criteria. And this is also, so failure becomes more than 3 times or absolute value of more than 4. And here urine output becomes less than 0.3 ml per kg per hour for 12 hours or anuria, 0.3 ml per kg per hour for 24 hours or anuria for 12 hours. So here also again the GFR gets added. So serum creat, GFR and urine output. So if anyone asks in Akin and Rifle, these 3 are the components that are taken into account. Okay. Now, next coming to early detection of AKI. So we must all be thinking that monitoring serum creatinine or urine output must help us in detecting AKI early, but that is not true. If you look at this graph, you'll know the fact. Okay. So if you see here, this is the serum creatinine and this is the GFR. Okay. This is the serum creatinine and this is the GFR. So if you see here, the initial kidney injury has started and the GFR has started declining. But then you'll notice the serum creatinine has not started increasing. There's a window of 8 to 48 hours before which serum creatinine starts increasing. So in this window, serum creatinine will not show us that the patient is in acute kidney injury. So it misses a crucial period of 8 to 48 hours. That is almost 2 days of GFR decline where we can intervene and save the patient from progressing into further stages of AKI. So to pick up AKI in this crucial phase is where the novel biomarkers to detect AKI came into picture. So like I said, serum creatinine is slow to rise. It might not rise at all for small decline in GFR, and window to rise is 8 to 48 hours. Now these are the novel biomarkers. You don't have to know them in detail, but you have to know the name at least because recently this has been asked. So first is serum cystatin C. Okay, so cystatin C can be measured in serum, it can be measured in urine. What is measured in the serum is more sensitive than creatinine and urine cystatin C can be used. Okay. Next is IGF-B7 and TIM2. So this IGF-B7 and TIM2 is used for earliest diagnosis. Within 12 hours of AKI starts, it can be used for diagnosis. Okay. So if they ask which is the biomarker which is earliest for diagnosis, then it is IGF-B7 and TIM2. Okay. And these are the protein excreted by the tubular cells, and their function is whenever injury happens, it stops the cell division. Okay, so that further cell proliferation and activity is prevented. So it's like a protective mechanism. So IGF-BP7 and TIM2 are the earliest biomarkers. Then next coming is KIM1. Okay, so the KIM1, it is produced from the proximal tubule of the kidney and it converts epithelial cell into phagocytes. So whenever the damage happens to the proximal tubule, this KIM1 is produced, that is kidney injury molecule 1 is produced. It converts this epithelial cell into phagocyte, which will go and do its protective function. Okay. Then what happens? This molecule is excreted in the urine and it can be detected in the urine. So we are going to see this molecule whenever there is injury to the tubule. It might be an ischemic insult or it can be a toxic insult. Okay, ischemic induced ATN or it can be a toxin induced ATN. Next is NGAL. Okay, NGAL is produced from the neutrophil. What happens is it increases only in the tubular cause and not in prerenal. So this is produced from the neutrophils and this gets activated only when tubular injury is there. It doesn't get activated otherwise. Other marker is interleukin 18, which increases in ischemic insult. So the molecules, just remember by name, cystatin C, IFB7 and TIM2, KIM1, NGAL and interleukin 18, out of which IFB7 and TIM2 are the earliest markers that you are going to detect. Now, the same thing, what are the roles of biomarkers? It is shown in this picture. So, first is a normal kidney. Then you find out increased risk of AKI. Okay. So, how do you assess this? You do early biomarkers. Like, for example, patient is volume depleted or patient is having a congestive cardiac failure. Patient has taken some nephrotoxin. So, in them, you assess this biomarker. In serum, you can use NGAL and cystatin. In urine, you can use NGAL, interleukin 18, KIM1, IFB7 and TIM2. So, we discussed all these things. Then once increased risk is detected, you can do primary prevention. For example, in cardiorenal syndrome, you can remove the nephrotoxic agents, give diuretic. If it is volume depletion, you can give volume to the patient. So, you do primary prevention. In the stage of primary prevention also, if you detect, these are the biomarkers that you can see. Like in serum, NGAL and cystatin, urine, NGAL and KIM1. So, you don't have to go to IGF-B7 and TIM2, which is used in the stage of risk assessment. Once the primary prevention stage, you can detect the other biomarkers. Okay. So, at this stage also, if you don't intervene, the damage has occurred and the AKI has started. Now, once the AKI has started, you can use markers like serum creatinine itself, which is available, or serum urea and cystatin C. Okay. Now, after this point, GFR will start falling. Okay. And then you start whatever your specific therapy you start. And if kidney failure happens, you put the patient on dialysis. Here, the prognostic markers which can be used is NGAL, cystatin C, urea, interleukin 6, urine is NGAL, KIM1. So, see, all these prognostic biomarkers are used here prognostically to see if the kidney damage is coming down. Another important test is furosemide stress test. I'll come to it soon. Okay. Then final stage is death. So, you understood that these markers can be used both for diagnosis and prognosis. Okay. Now, what is furosemide stress test? It's a simple bedside test that we use mostly in casualties in ICUs to determine the function or response of the patient. That is, if to basically prognosticate the patient, that whether this patient is going to deteriorate and need dialysis or this patient can be managed conservatively. So, what we check is urinary response to furosemide. We know that the furosemide acts on the sodium-potassium 2-chloride channel, right? So, if the tubular function is good, that is the kidney is responsive, then the patient should produce urine to furosemide. That's a simple concept. So, what we do is, if the patient is adequately hydrated, then we give 1 to 1.5 mg per kg dose of furosemide. Okay. That is, if it's a 60 kg patient, we give around 60 to 80 milligrams of furosemide. Then we wait for 2 hours. If the urine output is less than 200 ml, then we tell the stress test is negative. If it is more than 200 ml, the stress test is positive. That means the kidney is responsive and we can wait for dialysis. But if it's less than 200 ml, then this patient has high risk of progression to stage 3 and may require dialysis. Okay. So, this is about furosemide stress test. Now, just look at this diagnostic approach of AKI. Okay. First, this patient comes with elevated serum creatinine. Then you assess if baseline kidney function is available, and if serum creatinine is elevated at baseline or rise is not meeting the definition of AKI, then you classify the patient as CKD. That is, if probably the baseline patient is coming to you with 3 creatinine. Then you're seeing that patient has multiple reports of 3 creatinine of the past month, the months before that, then that goes to CKD, right? Then next, you see that serum creatinine is more than 1.5 times the baseline, or rise is more than 0.3 milligram per deciliter in 48 hours, right? So, in this situation, first you have to rule out obstruction, okay? So to rule out obstruction, the first thing you are going to do is you're going to do ultrasound. If there is evidence of obstruction, you do bladder catheterization or urologic evaluation. This we would have seen so many times in our practice where patient will come with a full bladder, urinary retention. So the first thing is do a USG, rule out any obstruction, and if obstruction is there, catheterize the patient, relieve it. Okay. If there's no evidence of obstruction, then you go for history, physical examination, lab testing, urine sediment estimation. In history, you're going to take history for any history of drug exposure, any history of volume depletion, like patient had any diarrhea, or patient has any cirrhosis, patient has any cardiac failure. And in physical examination also, you're going to look for signs for any acute glomerulonephritis. In lab testing, you're going to look for urea, serum creatinine. If it's glomerulonephritis, you're going to look for complement level, ANA level, and urinary sediment, the cast. I'll come to it later. So that will give us one etiology. So in that, if you're getting pre-renal cause, you give IV fluid challenge. If it's responsive, supportive therapy. If it is non-responsive, then you suspect the intrinsic cause. Now, what are the intrinsic causes? So we know the components of kidney, right? Glomerulus, tubule, interstitium, macrovascular, and microvascular. Now, glomerulus can be any acute glomerulonephritis like IgA nephropathy, infection-related glomerulonephritis, ANCA-associated vasculitis, SLE. Tubule can be acute tubular necrosis. Acute tubular necrosis can be caused by ischemic insult or by nephrotoxic insult. Okay. ATN can be caused by, all this we have discussed in the last chapter also, ischemic insult or nephrotoxic insult, right? And this nephrotoxic insult can be further by endogenous toxin like pigment, which can be rhabdomyolysis, which is myoglobin, or it can be hemolysis like hemoglobin, or it can be exogenous, where it is because of some drugs and toxins. Okay. Interstitium is acute interstitial nephritis. So in detail, we have dealt it within chapter of acute interstitial nephritis, where drug, infection, malignancy, autoimmune condition, all that can cause. Next is tubule, again intratubular obstruction by crystals or paraprotein. Okay. Macrovascular, so it should be involving the vein or the artery. So it can be renal vein thrombosis or renal artery thrombosis. Microvascular can be something like an atheroembolic disease or TMA. So we discussed all this. Okay. Now, how based on the pathophysiology, we classify renal failure into pre-renal, intrinsic renal, and post-renal. So how do we classify? So pre-renal occupies most common cause of AKI is pre-renal, which is 30 to 60% of AKI. Okay. Now, most important cause is volume depletion, which can be renal or GI or hemorrhage. It can be because of decreased cardiac output, like in heart failure, cardiac tamponade. It can be because of systemic vasodilatation, like sepsis, anaphylaxis, anesthetics, afferent arteriolar vasoconstriction. This also we have dealt in detail in the previous chapter, where the afferent arteriole vasoconstricts and the GFR reduces in the kidney. So it can be because of NSAIDs, calcineurin inhibitors, contrast, hepatorenal syndrome, and hypercalcemia. Efferent arteriolar vasodilatation, like in AC inhibitor or ARB. Okay. So all these are the causes. Coming to intrinsic renal, ischemic 40% of AKI. So most common is pre-renal. Then intrinsic renal is only 40%. In that acute tubular, first I told ischemic. Then it can be toxic, which is endogenous or exogenous. Exogenous is drug, right? Which can be aminoglycoside, lithium. So all these are the drugs which cause ATN. Amphotericin, pentamidine, cisplatin, ifosfamide, and radiocontrast. Endogenous pigments are rhabdomyolysis and hemolysis, already discussed. AN, again it can be drug-induced like penicillin, cephalosporin, NSAIDs, PPIs, allopurinol, rifampin, sulfonamide. Okay. See, don't remember all these. All these are just cumulative thing of what you have studied in all other chapters. This is nothing new. It can be infection related. It can be autoimmune disease or malignancy. Again, coming to the intratubular obstruction, it can be paraprotein like in multiple myeloma, crystals like in phosphate or tumor-lysis, ethylene glycol toxicity, or drug-induced like acyclovir, indinavir, methotrexate. Now, acute glomerulonephritis, like we discussed the causes, Macrovascular causes can be increased intra-abdominal pressure compressing on the renal vein, that is abdominal compartment syndrome, or bilateral renal vein thrombosis, or bilateral renal artery emboli. So all these things. Microvascular is atheroembolic disease, HUS, TTP, scleroderma renal crisis, and malignant hypertension. Okay. Post-renal is obstruction. It can be intrinsic, like it can be some stones or bladder outlet obstruction or neurogenic bladder, or it can be something extrinsic like a retroperitoneal fibrosis or a cancer obstructing the pathway. Okay. Now, how do we differentiate AKI versus CKD history-wise? So, CKD patients, they will have long-term history. Apart from it, the most important thing that differentiates between AKI versus CKD is in investigation. That is when we do USG, the kidney size will be reduced in CKD and normal in AKI. So now it's the time to recollect which is the CKD with normal kidney size, that is diabetic kidney disease, HIV associated nephropathy. So in these two conditions and amyloid, even though there will be CKD, there will be normal sized kidneys. Okay. Next is if you see the complications because of CKD, like if the patient has anemia, which is normocytic normochromic, if the patient has hypocalcemia, hyperparathyroidism, and also if the patient has hyperphosphatemia. Okay, so all these conditions that when present along with the patient's other features will suggest history of CKD rather than AKI. Then of course when you do urine analysis, you'll find variety of sediments in AKI, but waxy broad cast that is seen in CKD. Okay. Now, clinical and laboratory variables differentiating between prerenal and renal is, in prerenal history, you are going to have history of volume loss from GI, urinary, skin or blood, or reduced effective arterial blood volume. In renal, you are going to have drug or toxin exposure or hemodynamic change. Okay. Clinical presentation, these patients will be in hypotension or volume depletion. Here, nothing like that. Laboratory studies, bun to serum creatinine, that is urea will be elevated more than serum creatinine in prerenal. This happens because increased vasopressin levels are present in prerenal because there is volume depleted. Vasopressin increases the absorption of urea from the tubules. So this is why in prerenal AKI you are going to find increased urea more than creatinine. So more than 20 the ratio is prerenal, but less than 20 is renal. Okay. Sediment that you are going to see here is hyaline cast, and sediment you are going to see in tubular injuries, muddy brown cast. Urinary osmolality, since body is reabsorbing all solutes in prerenal failure, so urine osmolality is going to be very high, more than 500. Here the body is not able to reabsorb any solute or any water, so it's going to be pretty much dilute, that is going to be less than 350. Proteinuria is going to be very less, none to trace in prerenal. Here it's going to be mild to moderate. Urinary sodium reabsorption, like I said, because it's prerenal, volume depletion is there. Body is trying to reabsorb all sodium and water. So urinary sodium is going to be less than 20. Here it's going to be more than 40. Fractional excretion of sodium also is going to be less than 1. I'll come to this later. Here it's going to be more than 1. Fractional excretion of urea is going to be less than 35. Here it's more than 35. Instead of using, in some situations where we can't use fractional excretion of sodium, we use fractional excretion of urea. And there are no novel biomarkers for prerenal AKI. Remember this, prerenal AKI, no novel biomarkers. All novel biomarkers are for renal only because all these are excreted from the tubules. Okay. Now coming to talk about urea. So we know that the urea or the bun is to creatinine ratio is more than 20 in prerenal AKI. Okay. But that is because urea raises disproportionate to creatinine. But there are conditions other than AKI in which bun or urea raises disproportionately. This is when we are using steroids. Okay, when patient is on steroid because there is impaired anabolism or there is excessive catabolism like in sepsis. Okay, even in this condition, patient will have increased urea, or if there is a GI bleed. Okay, so in all these situations, you are going to see urea which is elevated. So isolated urea elevation, think about all these conditions. Then urea can decrease. For example, we know urea is produced in the liver. So if the patient has liver cirrhosis, then you can expect not to find the urea elevation despite renal failure. And creatinine will be more than 1 in pre-renal AKI when there is rhabdomyolysis, because creatinine is generated from the muscle. So when the muscle breaks down, creatinine is going to be more than urea. So that is seen in rhabdomyolysis. Okay. Next, fractional excretion of sodium. So we read about this in the 2 slides before this. What is the formula? It is the urinary sodium divided by serum sodium into serum creatinine by urinary creatinine. Okay, into 100%. So this comes as a percentage. Okay. Now utility is, what happens is, we know that in pre-renal AKI all the sodium is getting absorbed. So fractional excretion of sodium is less than 1% in pre-renal AKI. Okay, and in tubular injury it is more than 3%. Okay, but this is not absolute. In pre-renal AKI also, in some condition you can see this being more than 1% when there is going to be sodium excretion in the kidneys. That is when there is CKD, when there is diuretic use, or when there is IV fluid use. Similarly, in ATN also, sometimes it can be less than 1% when there is heightened renin-angiotensin-aldosterone activation, like in heart failure and cirrhosis or sepsis. Okay. Now, in condition where we use diuretics, you can't use fractional excretion of sodium. You can use fractional excretion of urea. Okay. So urea does not change with the diuretic. So any less than 35% becomes pre-renal. More than 35% becomes tubular etiology. Okay. Next, complement level in AKI. Complement level will be low in AKI because of glomerular disorders, like it can be TMA, that is HUS, or it can be because of any glomerular diseases like infection related glomerulonephritis. Okay, or it can be because of SLE. It can be normal in other diseases like IgA related nephropathy, or it can be in anti-GBM disease. So all these can present as rapidly progressing glomerulonephritis, or it can be in ANCA vasculitis. Okay. Now this is a urine picture depicting multiple casts. So this is normal epithelial cells. This is a hyaline cast which is mostly seen in a pre-renal AKI. This is a tubular epithelial cast which is mostly seen in ATN. This is this muddy brown cast which you are seeing, which is seen mostly in ATN because of rhabdomyolysis. This is an RBC cast. What you can see is RBCs inside. Okay, so you'll see this in glomerular disease, and this is drug induced. Okay, like crystalluria, like indinavir or acyclovir. Now, the same thing, urinary sediment in AKI. Normal is normal or few RBCs or WBCs or hyaline cast. This you can see in pre-renal, post-renal, or when there is arterial thrombosis or embolism, or there is vasculitis, HUS or TTP, or scleroderma crisis. Now, abnormal is when there is RBC or RBC cast, mostly seen in glomerular disorders like vasculitis, can also be seen in malignant hypertension and TMA. Okay. WBC and WBC cast, it's mostly seen in infection, we know that is pyelonephritis. Apart from this, it can be seen in glomerulonephritis and interstitial nephritis also. Apart from this, when there is rejection in the kidney or there is malignant infiltration of the kidney like in lymphoma. So these 5 conditions you see WBC cast. This is a very important table for you to remember. Okay. Next is renal tubular epithelial cell cast. So it is mostly ATN or ATIN, that is tubulointerstitial nephritis. Again, rejection you can see, and myoglobinuria and hemoglobinuria are again causes for ATN. So basically when there is tubular necrosis or tubulointerstitial nephritis. Granular cast. Granular cast again can be seen in ATN or glomerulonephritis or vasculitis or interstitial. It can be seen in any of these conditions. It just means that the tubules are shedding. Okay. Eosinophiluria is seen in two important conditions. One is allergic interstitial nephritis. Second is atheroembolic disease. But now the significance of finding eosinophils in these diseases are over. No one is going to check for eosinophils. We have other ways of diagnosing. Okay. Next is crystaluria. You see crystals like in acute uric acid nephropathy. Calcium oxalate you see in ethylene glycol toxins. Again, you see drugs like acyclovir, indinavir, sulfadiazine, amoxicillin producing some crystals. Okay. Now coming to some specific settings like ATN, acute tubular necrosis. It can be caused by ischemic or nephrotoxic insults. It can happen within minutes or can happen days after insult. Minutes or days after insult. The diagnosis is by taking history and by seeing urine. If you can see any muddy brown coarse granular cast, in history you will get history of the hypotension persisted for a long time or there was anuria. Renal biopsy, it's difficult to find this because mostly it happens in the medullary tubules. Like we already discussed in the previous chapter, it happens in the S3 segment of the proximal tubule or the thick ascending loop of Henle. So in biopsy, we are majorly biopsying the cortex and not the medulla. So it might be difficult to biopsy. And more so it is focal, not that in a tubule all epithelial cells are affected. One or two might be affected. So because of this, the diagnosis becomes difficult. Okay. Now AKI from intratubular obstruction. It can be either endogenous or exogenous. Okay. Endogenous, again, we know it can happen because of rhabdomyolysis or hemoglobin. Exogenous happens when we give any drug when they're at high dose with volume contraction. Another toxic material is ethylene glycol, which generally causes AKI after 48 to 72 hours. This happens because when ethylene glycol is converted to calcium oxalate, okay? Ethylene glycol is converted to glycolic acid, which is then converted to glyoxylate, and finally oxalic acid, which goes and combines with the calcium to form calcium oxalate crystals, and this goes and gets deposited in the urine. So immediately you will be able to see calcium oxalate crystals, but they won't be good enough to cause a renal failure till 48 to 72 hours after taking. Next is tumor lysis syndrome. Tumor lysis syndrome is just spontaneous lysis of the tumor cells after giving chemotherapy. Okay, so it happens when tumor cells which are bulky, which are mostly hematological malignancy in origin. And what happens is all the intracellular materials, maybe phosphate, potassium, and phosphate and potassium increases, right? So hyperkalemia will happen, hyperphosphatemia will happen, and even uric acid increases, causing hyperuricemia. Then what happens? All the calcium binds to phosphorus and there is hypocalcemia. So these four are the findings that you're going to find. And the urine is going to show this calcium phosphate crystals or uric acid crystals. Okay. Next, coming to rhabdomyolysis, it's nothing but the lysis of the muscle content. The etiology and pathophysiology we discussed in the previous chapter. What happens to the urine? Urine is going to be reddish brown urine, and mainly patient is going to come with muscle pain because lysis is happening. Now the interesting feature is that urine dipstick will be positive for blood because there is myoglobin. Okay. But if you see the urine routine, you will not find RBC. So this is one most important point that clinches the diagnosis of rhabdomyolysis. That is, urine strip or reagent test shows positivity for blood, but no RBCs in the urine routine. And only thing you'll find in the urine routine is pigmented granular cast. Okay. So there is going to be elevated creatinine kinase. Generally, they say if the level is more than 20,000, it indicates that the AKI can be severe, but you cannot find any specific correlation. Even levels of 5,000 can cause AKI. And another one you're going to find is urinary myoglobin. And AKI and myeloma, we know that there are multiple causes, like it can be pre-renal, it can be volume depletion like vomiting, it can be because of hypercalcemia, it can be because of myeloma cast nephropathy, light chain deposition disease. So amyloidosis, multiple causes are there. Okay. Diagnosis is basically by urine and blood. In urine, this shows an important marker, that is urine routine will show nil protein, okay, or minimal protein, because this detects only albumin. But if you do 24-hour urinary protein, which detects all proteins, then you're going to find very high protein. So this is like same rhabdomyolysis, where in the strip test, you're going to find blood, but in the routine, you're not going to find anything. Similarly, here in the routine, you're not going to find protein because it detects only albumin and not the light chain. But when you do 24-hour urinary protein, you're going to find high levels of protein. Okay. Now, contrast-induced nephropathy, this generally happens after exposure to intravenous or intra-arterial contrast, like given in contrast angiography. The incidence of this is somehow less than 1% only. There are very important risk factors to this, like patient who already has a pre-existing diabetes or patient with congestive heart failure with poor ejection fraction, high volume of contrast, okay, or hyperosmotic contrast or hyperosmolar, that is osmolarity is very high of the contrast, or if the patient is on any nephrotoxic medication or diuretics. So all these becomes risk factors if the patient has any anemia. So all these becomes risk factors of acquiring contrast-induced nephropathy. Okay. Generally, AK detection happens after 24 to 48 hours. If it happens, it's generally acute tubular necrosis, and it is generally short-lived, and there is no specific therapy required for this contrast-induced nephropathy. So thank you, friends. I hope I improved your understanding of this chapter. We'll come back in the next section discussing about the management of acute kidney injury. Bye till then.